Good afternoon, everyone. My name is Rebecca Cunningham. I'm an occupational therapist and clinical faculty member at the USC Chan Division of Occupational Science and Occupational Therapy. And I'm really pleased to be here today to speak with you about chronic fatigue as a symptom, its impact on occupational performance, and the strategies that we can use to successfully manage it. So let me look over my learning objectives. So in addition to the learning objectives that are outlined here, my hope is that I'll be able to provide you some additional vocabulary and language that you can use when talking about fatigue with clients, or in relation to your own experience with fatigue, or in speaking with family, friends, and other loved ones who may be experiencing fatigue, or who you want to be able to experience or understand your own experience of fatigue. So I hope that this session ends up being kind of as applicable as possible. So I would encourage you to either use your own experience of fatigue, or a client's that you work with, or another loved one's experience of fatigue as a reference point for applying some of these concepts, vocabulary, and interventions that we'll be discussing this afternoon. And please feel free to put questions in the chat. I'll try to keep an eye out for those notifications as we go along. So first, I want to talk a little bit more about what occupational therapy is and my practice in lifestyle redesign. So broadly, occupational therapy, or what my job is as an occupational therapist, is to help individuals to better be able to participate in the activities that they want and or need to do that are meaningful to them, that they may be having a difficult time engaging in because of injury, recovery from surgery, or illness, including some type of chronic condition. And we do that really through promoting and engaging our clients in meaningful occupations. And when I use the word occupation, I'm really meaning any activity that meaningfully occupies their time. So that could be something as simple as brushing one's teeth, to something as complex as preparing for and planning and implementing a Thanksgiving meal, although I know that's probably going to look a little different this year. So my job as an occupational therapist is really to help individuals to better participate in their day-to-day lives. So that's what I broadly do as an OT. More specifically, the type of OT that I practice is called lifestyle redesign. So this is the process of helping individuals to develop and integrate healthy habits and routines into their day-to-day lives, and really helping them to change the way they go about their activities with a number of goals in mind. So first being to help them to better manage the symptoms that they have of a chronic condition, whether that's diabetes or multiple sclerosis or depression. In addition, we want to be helping them to improve their occupational performance, because again, at the core of what I do, I'm an occupational therapist. And then finally, our third goal is to improve their health, their well-being, and their quality of life. Because one of the core principles of OT is that we can improve one's well-being and quality of life by getting individuals meaningfully engaged in activities and occupations. So I practice lifestyle redesign at the USC OT faculty practice, where usually we are providing one-to-one and group services in person out of our many on-site clinics. However, because of the COVID-19 situation, I think it was either March 16th or March 17th of this year, we transitioned all of our service lines to 100% telehealth. So I was asked to speak a little bit about my experience of providing telehealth-based occupational therapy services. So I don't want to take too much time, because I think really the core of this talk is about fatigue. But broadly, I think our transition to telehealth has been really smooth. I would say about 75% of our caseloads at the time of transition went from in-person to telehealth-based services. And we've actually had some really nice silver linings come out of this COVID-19 experience related to telehealth service delivery. So our service line has certainly been more accessible since we have been providing telehealth. OT is a state licensed profession, so we can only provide services to individuals who are within the state of California. But when we were in person, obviously we were limited to a service area of really Los Angeles County, Ventura County, and Orange County, really individuals who could travel to the clinic reasonably. But now I have individuals that I'm working with north of San Francisco, south of Orange County, into East counties in San Bernardino, or up into Kern County, Bakersfield, Fresno area. So telehealth has really been able to expand accessibility to our services. In addition, because most of the individuals that I work with have chronic fatigue, where they once were really only able to come into clinic maybe once a month or once every other week because the travel to and from the clinic was really exacerbating some of their fatigue symptoms. Now I'm able to see them on an every other week or weekly basis because the travel or that travel barrier has really been lifted. And so a lot of my clients that I'm working with have been able to attend more frequently and therefore have been able to make progress at a more rapid rate in terms of understanding their fatigue and being able to better manage it on a day-to-day basis. So my hope is that beyond this COVID-19 situation and the public health emergency order that has really enabled reimbursement and coverage for telehealth-based OT services, is that we'll be able to advocate successfully to have continued reimbursement for telehealth and telemedicine services, not just for OT, but across the field of medicine as we move beyond COVID-19. So before we get into the interventions and what is going to be the core of the talk today, I want to speak a little bit about the connection between fatigue and occupational performance. So as you can imagine, fatigue can take a pretty big, I mean, it's our energy, right? So it plays a really big role in terms of how we're able to get through our day. So because the core of my caseload and work is with neurological populations, all of the research and statistics that are presented here are on the diagnoses that I work with the most. So that being multiple sclerosis, Parkinson's disease, epilepsy, post-stroke, and then I work with other functional neurological conditions. And I was looking for stats that were also related to the general population. And the most recent ones that I could really come up with for the country, or for our country, the United States, were from 2004, and they were specifically looking at general population older adults. But what I found was really alarming was that it was 25% to a third of older adults in the general population were experiencing chronic fatigue. So I think that speaks to the pervasiveness of this issue within our country, but also these stats here on this slide speak to the pervasiveness of fatigue within these neurological populations. And really, many of the diagnoses listed here, fatigue is not necessarily the first thing that comes to mind when you think about Parkinson's disease. Usually people, what first comes to mind is like the tremor, the changes in gait, maybe changes in cognitive function, but fatigue is experienced by 50%, and 50% of individuals with Parkinson's report it as their top 3 most disabling symptoms. So it's not necessarily their tremor and their gait changes that are most disabling, it's the fatigue itself. And so what we're seeing in these populations is that the fatigue is really resulting in individuals leaving the workforce much earlier. They have barriers in being able to participate in meaningful social activities and leisure activities, which then reduce their quality of life and their feelings of self-efficacy. So this means that we really need to be addressing fatigue successfully so that we're helping people to be able to re-engage with activities that add meaning to their life and purpose to their life. So what we see and what OTs look at are these areas of occupation. And what we see is that all areas of occupation can be impacted negatively by fatigue. So first being our activities of daily living. So these are things like getting dressed, bathing ourselves, being able to toilet successfully, being able to navigate the physical spaces of our home. Next are our instrumental activities of daily living. So these are more complex tasks that often have community-based components, such as going grocery shopping, running errands, managing a checkbook, being able to take care of our children, and exercising. And then we have rest and sleep. I'm going to come back to this because oftentimes people give me a question when I say that rest and sleep can be impacted negatively by fatigue, but it can. Then we have school and work. We have other community-based and social activities and our leisure activities. So in terms of rest and sleep, because individuals with fatigue often feel like they don't have enough energy to engage in the activities that they want to and or need to, they often end up spending more time than the general population napping or engaging in prolonged sedentary activities, which can actually lead to reduced energy expenditure. And in order to sleep successfully, we need to expend sufficient energy for our sleep drive to be high enough for sleep to take place successfully. So in more of an indirect way, fatigue ends up negatively or can end up negatively impacting our ability to sleep successfully. So what the research shows, and again, this research that's listed here is focused predominantly on neurological populations, but could easily be extrapolated out to other diagnoses and conditions, is that the fatigue management interventions that have evidence-based success include group interventions, behavior change programs, consistent eating routines, etc. You can read the list here. The ones that I'm going to focus on predominantly today are going to be our behavior change programs and our activity pacing and energy conservation programs and interventions. The reason being is those are the ones that most closely align with addressing primary fatigue. So we'll be talking about the different types of fatigue momentarily. One note about these different fatigue management interventions is that depending on the diagnosis, some may or may not be applicable. So for example, the cooling strategies box that's listed on this slide is more applicable to diagnoses such as multiple sclerosis, in which we know there is a temperature sensitivity component, which can make fatigue worse or worsen it over the course of the day. And then another example is the energy conservation box that's listed. For individuals with Parkinson's disease, the research actually shows that activity pacing is effective for individuals with Parkinson's, but energy conservation is not. So we want to make sure that while we, yes, are looking at broadly which interventions are shown to be efficacious across neurological populations, we also need to be taking into consideration diagnostic specific factors and studies. So now we're going to get into what I call fatigue basics, but this is basically the terminology that I end up teaching my clients so that they better understand their fatigue. And not only that, but can better explain it to their healthcare providers, to their friends, families, and other loved ones. So first is just a definition of chronic fatigue. So what I really like about this definition is that it highlights that fatigue can be physical, cognitive, and emotional in nature. So typically when individuals think about fatigue, they think about physical fatigue, right? So difficulties moving their body through space. But anecdotally from the clients that I work with, what most individuals find to be most fatiguing or exhausting is the the emotional or cognitive fatigue, or those high cognitive and emotional demanding tasks that can influence their overall fatigue presentation. So we don't want to just be thinking about fatigue as a physical symptom. We also need to be taking into consideration fatigue as an emotional and a cognitive symptom as well, and address it accordingly. So one of the first things that I always talk with my clients about is the difference between the term tired and fatigued. So often we think of tired looking like this, and we think of fatigued looking like this. So they may outwardly look the same, but inwardly they feel very different. So by definition, tired is in need of rest or sleep, or just weary feeling. Whereas the slide previously, you saw this much more complex definition for the term fatigue. So it's really important for our clients to be differentiating between these two terms. And when they're trying to describe their symptoms to somebody, to use the accurate terminology of fatigue. Because if we use the word tired to describe fatigue to a loved one, that loved one is going to say, oh, well, I know what tired feels like. That's what I feel like at the end of the day after a long day of work. But I sleep and then I wake up the next day and I feel just fine. And that can lead to a negative interaction and the individual with fatigue having their lived experience feel diminished. Because the response that you're going to get from that individual is, oh yeah, I've been tired a lot lately too. And those two experiences are very different. So tired can be remediated through simple rest, and the individual is going to wake up the next day feeling completely refreshed. Whereas someone with fatigue is going to wake up feeling fatigued. They're going to feel fatigued all day to varying levels of severity, and they're going to go to sleep fatigued. And they could get the best night's sleep in the world, and it's still going to feel like fatigue every moment of every day. And that is a huge difference that we need to help our clients to understand and help them to use the right terminology when describing it to other people. So the next thing we want to keep in mind is this term lazy. So I can't tell you how many times that I've had a client describe themselves as lazy because they didn't get to unloading the dishwasher, or they didn't get to folding that load of laundry and putting it away, but they intended to. And so whenever I hear my client with fatigue using the term lazy, I, in a very kind and generous manner, kind of interrupt them and say, look, lazy is both literally and figuratively a 4-letter word in the realm of fatigue management language, and we want to try to deviate away from using it. because by definition, lazy is having the energy to do something, but choosing not to, right? Whereas fatigue, the reality of it is that we have insufficient amounts of energy to engage in all of the activities that we want to. So getting to that, folding that load of laundry or putting the dishes away from the dishwasher may feel lazy in the moment, but if we literally don't have the energy, then it's not really laziness, it's fatigue. So we want to correct the use of the term lazy so that we reduce the risk of it becoming internalized and becoming a part of their identity, because that can lead to feelings of low self-efficacy and reduced quality of life. So now we're going to get into the types of fatigue. So the two types of fatigue that I spend the most time talking about with my clients is primary versus secondary fatigue. Primary fatigue, or what we call lassitude, is a direct result of the underlying diagnosis and its disease process. So this is the type of activity that is not going to be remediated through simple rest. It's something that's always going to be constant and present at some underlying level and level of severity every single day. Whereas secondary fatigue is due to all of these other factors that are listed here that are not related to the disease process itself. So when we are managing and working on fatigue with clients, we need to address both fatigue types in order to truly be addressing their overall fatigue presentation. And we have to do that in parallel at the same time. So the goal is to try to remediate or correct as much of the secondary fatigue as possible, and then you compensate and work around the remaining primary fatigue that we have left over. But you have to address both in order to successfully address overall levels and presentations of fatigue. So in addition to our primary and secondary fatigue, we also have fatigue types based on time, right? So we have acute fatigue, which would be less than 6 months, usually due to a short-term circumstance or stressful event. And then we have chronic fatigue, which is 6 months or longer and is usually emerging with longer-term issues such as a chronic condition. And then finally, we have central and peripheral fatigue. So central fatigue is really highly correlated to primary fatigue. It is going to not be remediated through simple rest, and it's this kind of full body exhausted feeling that typically has these physical, cognitive, and emotional components. Whereas peripheral fatigue is a temporary depletion of energy that can be remediated through simple rest. So peripheral fatigue is more in alignment with our secondary fatigue type. So as I've already mentioned, we have to look at the overall fatigue presentation. So therefore, we have to take into consideration both primary and secondary fatigue, as well as emotional, physical, and cognitive fatigue types. So as you can see, fatigue is a very complex symptom to manage because of the leveled layers that are going on and feed into the overall fatigue presentation. So we have to take into consideration all of these things. So the final term that I want to share with you is overexertion and the overexertion cycle. So overexertion is the process of just overdoing it, right? Doing more than we have the energy available to. So that ends up looking like I have energy or I feel good today, so I'm going to do all of the things. When we have chronic fatigue, that's a problem because even if we feel good, we still have limitations on the amount of energy that we have available. So when we do all of the things and end up overexerting, we end up paying for it and feeling much worse or flat as a result. And so what can happen is you get into this pattern of overexertion or an overexertion cycle where I feel okay, so I do all of the things and I pay for it and I feel really bad. Maybe for one day afterwards, maybe for 2 or 3, for some people longer than that. And then they feel better again, so they do everything that they haven't been able to do in those preceding few days. And then you just up and down, up and down. And the problem with this fluctuation in feeling is that individuals can start to feel like they are out of control or that their fatigue is unpredictable, when in fact, it's more predictable than we think that it is. So the crux of it, right? So we understand that fatigue is a really complex symptom. Most people find that it's incredibly hard to manage. So what do we do about it? So fatigue management interventions are comprised of everything that's listed here. As I mentioned earlier, the remainder of the talk is going to focus predominantly on the primary fatigue interventions because those tend to be the harder behavior changes to make. Most often because individuals feel like it's them giving up I've heard some people describe it as that, or they describe it as, if I do this, then I'm going to view myself as less than. But really what it comes down to is that the individual is still comparing themselves to who they were pre-chronic fatigue. And so in addition to just walking them through what all these different strategies are, we have to start trying to shift their mindset to be okay with using these interventions at the same time, and not having the barrier of who they were before, limiting their capacity for integrating these things into their day-to-day processes. So primary fatigue interventions consist of the 3 categories that are listed here. So we have activity pacing, energy conservation, and energy optimization. We're going to be going into detail or further detail for each of these categories on subsequent slides. And we're going to start with activity pacing. So most people, when they first hear the term activity pacing, they immediately think, oh, well, that's just slowing down and taking breaks. And at its core, yes, that's what it is, right? We're trying to help people to slow down the pace and the rate at which they're going through their day and integrate more breaks so that they're at a reduced risk of overexerting and paying for that energy expenditure. However, if you just describe it like that, there's very little frame of reference for how logistically and pragmatically to implement activity pacing. So what I hope is to offer you some strategies or some hard and fast kind of tools to use to help clients or your own experience of fatigue integrate these activity pacing or this concept of activity pacing into your day-to-day. So broadly, we can pace ourselves on a micro level or a macro level. And in order to manage fatigue effectively, you have to be adept at doing both. So we're going to start with micro. So essentially, activity pacing at a micro level is working within the confines of one activity, right? And applying activity pacing to that one activity. The example that's highlighted here is doing laundry, right? And basically what this individual is doing is checking in and taking a micro break after every step of the task. And it's this check-in that is crucial and is the critical component for activity pacing. Because so many individuals with chronic conditions learn over time to just like put blinders up and ignore what their body is telling them, because if they can ignore their body's experience, then they feel like they can keep going. But what that leaves us open to is overexertion and feeling much worse as a result. So during these check-ins, what we're really doing is completing a self-assessment of how we're feeling. Now, again, that sounds very broad, right? What does that actually look like? So the reality is you want to individualize it to meet the needs of each person. But a quick kind of version or starting point that I usually encourage my clients to use is asking themselves, how am I feeling physically? How am I feeling emotionally? How am I feeling cognitively? And they can have like a qualitative response to that, or they can use a numerical rating system. They can use low, mod, high. They can do whatever they want. But the intention of the self-assessment is to ensure that the next decision that they make is based off of how they're feeling and not like time, right? Because in order to really manage a symptom effectively, we have to be aware of how it presents and how our reactions, actions, and behaviors influence it. So as you can see, this first check-in that this individual is doing after they sorted the laundry, they're checking in and they're recognizing that their fatigue is not increased. So they keep going. And then they carry the bags downstairs one at a time. Once that's done, they check in again. Fatigue is increased slightly. So based off of that assessment, they choose to take a 2-minute stretch break. For this individual, that helps them return to baseline and they can continue with putting the laundry in the washer, right? And then they continue throughout the task. But what we really want to happen is for the next decision to be based off of that self-assessment so that we're making a health promoting decision that is going to benefit the management of the fatigue. So you can break down micro level activity pacing by using steps of a task, or you can use time. So the Pomodoro technique is first and foremost a time management technique, and that's usually how it's described. However, I've adopted to like using it with my clients with fatigue management as a very structured approach to micro level activity pacing. So the premise is that you work for intervals of 25 minutes And then as soon as that 25-minute timer is done and goes off, you transition into a 5-minute break. So you alternate between intervals of productivity and intervals of break or rest, back and forth. And then after the 4th interval of productivity, you then take a longer break, 15 to 30 minutes. So what this basically gets you is approximately 2 hours worth of productivity while still integrating these breaks sporadically throughout and creating opportunities for self-assessments and check-ins so that an individual can make a determination about their next interval of productivity to pick a task that's going to meet where they're at in that moment, okay? So this is something that I use with my clients quite often to help with the initial phases of learning how to do micro-level activity pacing. And then on the flip side, you have macro-level activity pacing. So this is taking that same premise and using it on a larger scale. So the 2 examples that we have here, the one on the left is making a meal for friends, right? So you're taking what is conceivably a pretty big project or high energy expenditure task for a client, and you're breaking it down into those tasks and then spreading it out over the course of a few days, as opposed to trying to do everything on the same day and risking overexertion. So you can look at it over the confines of a course of a few days, and that's macro level. Or you can look at the course of one day and have that be a macro level activity pacing. So the example on the right is appropriately engaging in a day at a conference. So making sure that individuals who have fatigue are taking breaks between sessions, because even though, yes, sitting in a session is not physically demanding, it's cognitively demanding, and so can be just as fatiguing as a physical activity or even more so. So, but again, creating these opportunities for self-assessments and check-ins so that we can make decisions that are going to benefit the management of our symptom or our fatigue in this case. The next activity pacing strategy is activity shifting. So basically what this boils down to is alternating back and forth between types of activities that are going to reduce the overexertion risk. So you can activity shift by any of the methods listed here and any other method that you come up with. These are just the 4 that I usually review with my clients. So you can alternate between restorative and depleting activities. You can shift between or alternate between activities that have more of a physical, a cognitive, or an emotional demand or requirement. You can shift between high, moderate, and low intensity activities, so taking the type of energy demanded out of the equation, just looking at the overall energy expenditure. Or you can look across different categories, right? So productivity, self-care, rest, play, okay? But we want to help our clients to find one of these that resonates most for them so that they can start intentionally planning their day from this perspective of shifting and creating opportunities to move back and forth between activities that are going to be energy depleting and or high energy expenditure to ones that are lower or restorative in nature. And this will help to reduce the overexertion risk. Next is activity simplification. So this looks very similar to the example on the left from the macro level activity pacing slide. Basically what we're doing is we're analyzing a project or a complex task or activity. We're breaking it down into its component parts, and then we're spreading them out over time so that, again, we're reducing the overexertion risk and helping people to pace themselves on a micro or macro level. In addition, when we break it down like this and really identify the component parts of a task, we're much better able to delegate things. And when we delegate, again, we're going to reduce the overall energy expenditure for our individual with fatigue. So these examples that are listed here are actually examples that come from my work with my clients. These are things that we worked through during different parts of the year to come up with solutions so that the individual with fatigue was not overexerting at the end or during different parts of these processes. The next strategy, or really the last strategy for activity pacing, is limit recognition and adherence to those limits. This is often the hardest one because, again, it requires individuals to be aware of what their body is telling them and really be engaging in these frequent check-ins or self-assessments. So what we're really looking for here and helping our clients to do is identify warning signs that their body is telling them that they're getting close to the point of overexertion. So for some, that could be starting to make errors in their work, or reading the same sentence over and over again, or physically bumping into things, dropping things, yawning even can be a sign. But so the first step is helping individuals to identify all of their warning signs that they may experience, and then trying to sequence them in order so that we can find the first or the first two warning signs that they experience and use that as the point to cue in and start making changes. Because if we wait until that last warning sign before overexertion, it's probably already too late. So this can be a really helpful activity to work through with clients, but can also be a really challenging thing to follow through with. So related to activity pacing is this mindset I run into a lot with my clients, that they'll often, I know when it's happening because they'll say something to the effect of, well, I just push through my fatigue, right? Or if I push through, then I get everything done, and yeah, I don't feel well, but it's done. So when I'm working with, and they don't have to be athletes in order to develop this mindset. Athletes tend to be the ones who do it most because they learn to play through pain and fatigue and soreness and stiffness. But you can have other students or other individuals learn these types of behaviors from different experiences over time. So what we want to help individuals learn is that their activity choices influence their fatigue and may or may not lead them to overexertion and feeling worse as a result. So we want them to recognize when it's important to push and when it's not. And usually when it's important to push is when the activity is truly meaningful for them. So for example, I worked with a client who had MS and she loved going to music festivals. They were like her favorite thing to do. And she would always feel really bad after the weekend was done. And she'd have to call out from work, and she'd be out probably the office for 2 days, and she'd always feel really guilty about it, et cetera, et cetera. And so what we did is we analyzed how she was actually engaging in the music festivals. And we realized through that analysis that regardless of what modifications that we made, she was likely going to push herself during that event and end up overexerting. So instead of feeling guilty and reactionary in her response to the overexertion, we decided to be proactive. And we talked about her just planning to take the 2 days off after the music festival so that she felt more in control. Because what happens when we're reactionary is that we feel, again, out of control and that our fatigue is unpredictable. When in reality, it's usually fairly predictable because of the choices that we're making. So we want to try to reduce people from pushing, but we want to respect the activities that are going to be worthwhile pushing through and for. So energy conservation is our next category of interventions. So I'm just going to spend this slide on this because I feel like these are more straightforward. But really what we're trying to do is take an activity that has a certain amount of energy that's demanded of it or required, and changing it or modifying it to reduce the overall energy expenditure required, which then helps to conserve energy for other things later on in the day, and at the same time reducing overexertion risk. So activity modification could look kind of like what this individual is doing in the picture, right? We have her seated, which is going to reduce the energy demand. She's using an adaptive equipment to catch her peelings, so she's not having to like raise her shoulders in order to use the equipment, which she would potentially if she was sitting at a table. And she is practicing good, proper body mechanics. I mean, this is a much less energy requiring version of peeling potatoes than if she were standing at the counter. And then for seated positioning, we do want to encourage individuals to sit during like especially repetitive high energy demand tasks, but we want to make sure that we're still avoiding prolonged seated or sedentary activities because that can also contribute to fatigue. And then we want to delegate when possible. So, but what's really important is to talk with your clients about which activities are meaningful for them to keep doing and which ones are not meaningful for them to keep doing. Those are the ones we should delegate, because we don't want to delegate away the activities that are actually meaningful to the individual, because those are worthwhile use of energy and time. And then finally, we want to modify the environment. So we want to be thinking about temperature. We want to be thinking about work surface heights, where we're storing things to make them more easily accessible and less energy demanding to access them. So all of these methods can help to reduce energy expenditure, therefore conserving energy use over the course of the day. And then the final category of primary fatigue interventions is energy optimization. And I'll expand on each of these in subsequent slides. But basically what we're trying to do is use the individual's own energy patterns to plan out their high, moderate, and low intensity activities over the course of the day so that we're seeking energy efficiency. So in order to really support individuals in kind of buying in to this category of strategies, we need to talk about scheduling and planning. So most people, when they're planning out their day, they do so from a time efficiency perspective, right? We're trying to cram in as much as we can in the least amount of time as possible. Unfortunately, that does not work when we have chronic fatigue, because again, as you're going to be saying over and over, that's going to increase the risk of overexertion. So what we have to help our clients understand is that instead of working from this perspective of time efficiency, we need to first and foremost plan our day from an energy efficiency perspective, right? And then time efficiency can come second, because time is constant, right? There's 24 hours in every day, where if you're somebody who sleeps 8 hours, you're approximately awake for 16 hours of those days, which leaves those 16 hours for you to use. So that's constant. Energy and fatigue is what is going to be variable and is going to change every day. Thus, that's what we need to plan by first and foremost. So, which sounds great in theory, but how do we actually do that practically? So there are a few things that we need to kind of put together in order to make that happen. So first, we need to understand how much energy we are devoting to different activities. So there are different models to use. The spoon theory is probably the most commonly known model to use. It was developed by a woman who had, I think, fibromyalgia. And she developed it when she was at lunch with a friend and trying to describe what fatigue felt like. And out of that conversation, she came up with this model in which basically the idea is that the individual with chronic fatigue wakes up with 15 spoons every day. And each spoon is a unit of energy. And each activity that you engage in is going to cost X amount of spoons or X amount of energy. And so the idea is that you plan your day based off of your planned energy expenditure first and foremost before time efficiency. And this is one model that you can use. I have some clients who feel like it's better used to be able to describe fatigue to their loved ones, but doesn't allow for flexibility of use. And what I mean by that is, like, grocery shopping is listed here as a 4-spoon activity. Depending on one's fatigue presentation, it's not always going to be a 4-spoon activity. So there is some challenges with implementing this on a regular basis, but it's a really nice starting point and can serve as a really nice guide and set of language and vocabulary to utilize with friends and family who don't experience fatigue. Another model that I think some of my clients like more, because there allows for variability and change in energy expenditure for each activity, is the water pitcher theory. So the idea is that you wake up with X amount of water in your water pitcher, and you have different cups that are going to represent different activities in your day. And it's your determination and job to figure out how much water you're going to put in each cup, i.e. how much energy you're going to devote to each of these activities based on how much energy you are presenting with that day. So in this first example, this individual is starting off with a full water pitcher. So they're giving a lot of their energy to playing with their grandkids, some more energy, about half of a cup's worth to gardening, maybe a fifth to a fourth of a cup's worth of self-care, and a little bit to housework, right? But still able to do 4 things in that day, given the energy that they have. However, if you wake up with less than full water pitcher, you then have less energy to work with. So as you can see, the amounts of water in each of the cups have changed significantly because of the higher fatigue level, and housework is what kind of got the axe, right? So this often ends up being a more realistic theory or model to use, or more helpful, because it feels more practical to the variability that fatigue can present from day to day. But I've heard other clients use like money in the bank or charge in a battery, right? Or battery use. So there are different models. The important thing is helping your client to find one that really works for them in a practical sense. And then in order to really use the water pitcher theory or the spoon theory, we have to have the individual, or we need to help the individual understand which activities fatigue them the most. So sometimes the fatigue diary can be beneficial, not that they need to keep it permanently, but at least do so maybe for a week. Some people even do it for a month to really capture the scope and breadth of the activities that they engage in, so that we can really start to pinpoint which activities are the most depleting. In this example, the 15-minute shower, their fatigue went up 2 points, and probably due to increased energy demand from having to stand the whole time, and the hot water might have exacerbated things. But this can be a really helpful tool for our clients to increase their awareness and insight into how their fatigue presents. And then we want them to really estimate what their natural energy patterns look like. So when is their highest peak, i.e. when do they have the most energy versus when do they have the lowest energy? Because the time of day when they have the highest energy, that's where we want those highest energy demand activities to go, right? We thus optimizing the energy that we have available and really working from an energy efficiency perspective. Because if we try doing something that's really high demand during a time of day when we have little to no energy, that's just going to end up being frustrating, probably stressful, and potentially overexerting. And people can use this kind of model or whatever they choose to really track their natural energy patterns. And then finally, we want to come up with some sort of activity energy demands chart, because this can therefore act as like a menu or a starting point for people to start to plan out their day from an energy efficiency perspective. So typically we have them identify activities that are low, moderate, and high demand, and then identify the energy types that are demanded of that activity, and finally, whether it's restorative or depleting. But by capturing all of this data and categorizing things in this way, it makes planning out the day much easier and supports scheduling from an energy efficient perspective. And finally, we've talked a lot about primary fatigue interventions. It's really important to still focus on secondary fatigue interventions. Briefly, we want to increase sleep. We want to increase exercise, especially aerobic activity. We want to engage in emotional regulation activities that are going to help manage the emotional fatigue that one experiences. We're going to want to make sure that people are eating frequently so that we're managing their blood sugar levels, which will help influence energy. We want to help them find balance amongst their different activities. We want to manage their medication routines, especially if side effects from medications are influencing their energy or fatigue presentation. Ergonomics and body mechanics and using proper body alignment and positioning also can make activities more or less energy demanding. And then we want to make sure that we're engaging in rest routines and truly restorative activities, not things like scrolling through Instagram on our phone, which actually tends to not be very restorative. So those are some of the secondary fatigue areas that we want to, again, look at and address in concert, in parallel with the primary fatigue interventions. So what I hope this talk has left you with, is some new vocabulary and language to use surrounding describing fatigue and addressing it in your practices. And hopefully has left you with the understanding that while fatigue can feel unpredictable, we have more power and control over it than we think that we do, and we can have more influence if we better understand the way that our symptoms or our fatigue presents and how our activities and choices influence it. And that we can make changes in fatigue and improve the management of it, but it can take a lot of work, and we often have to shift our mindset and some of our perspectives about our activity choices in order to make that happen. So I know that was kind of a sprint, but I want to thank you for your time this afternoon, and I hope that you now moving forward can take more explicit and tangible fatigue management strategies into your own life or your health or in your healthcare practice. So thank you so much for your time. If anybody has any questions, I'd be happy to use the remaining time to respond to them. So it looks like Marie says, I think medical students and nursing students should have this in their curriculum. I agree, Marie. I work actually with, our clinic receives a number of referrals from the medical school program. And this is something that I often talk with them about because overexertion risk is so high in those educational programs and in the field. Yes, all of you are taught to push and push through. And unfortunately, that can work temporarily, but is not a long-term solution and can lead to burnout. And something that came up quite a bit in our keynote speakers today was this idea of compassion fatigue. And those things just end up detrimentally affecting our careers and our learning processes. So I'm glad that you recognize that some of these types of principles and ideas would be beneficial to integrate into not just medical students and nursing student programs, but kind of across the board with healthcare programs, because allied healthcare professionals are just at a higher risk of burnout and fatigue. Thank you for your observation.
Thank you so much, Dr. Cunningham. And I know you, adding on to what Marie was saying about medical students, I'm also a medical student at USC, second year medical student, and I actually utilize the occupational therapy services for lifestyle redesign earlier this year. So
well, hopefully you found them to be helpful.
Yeah.
Good.
I'm not sure if you know, like, the staff that I work with, Lindsay Reeves.
Oh yeah, I know Lindsay. Yeah, we share an office when we're actually in clinic. We share an office.
Yeah, I did telehealth with her.
Nice. So. She's great.
Yeah.
Well, I'm glad that you found it to be helpful. And I saw in the Q&A, hi Nora. It was nice. I'm glad you were able to join. If you have any follow-up questions, Nora, feel free to ask me in clinic. Marie, yes, there is a stigma in healthcare. And in our society as a whole, I think that there's this perspective that we need to be productive all day, every day, anytime we're awake. And that if you're tired and fatigued and close to burning out, that's like an achievement or something that you should work towards. And, maybe for some people that works, but for most people, that's just not sustainable long-term. And I think the healthcare field as a whole needs to shift away from that. But I think our society as a whole needs to shift away from that. And that's gonna take time. Well, if anybody has any additional thoughts or questions, you have my email address listed on the slide here. Please feel free to reach out to me. I'm also easily found just by searching USC in my name. So hopefully today was helpful, and thank you everyone for your time. Enjoy the rest of the conference.